Well, why don't we go ahead and get started here with our program? So, want to thank everybody who's taken the time to join us. This is I can't think of a more important topic that we've ever covered on any Hent hosted webinar or live stream. And so, I want to thank Dr. Phil Eskew, who is a triple threat. He's got a DO, a JD, and an MBA. I've heard him often described as the smartest doctor I know by other smart doctors. And yeah, I just want to thank him for joining to share what's really his unique perspective, both from the medical side and the legal perspective, as well as a business perspective, on COVID-19 and and how practices and what practices can do to be preparing right now to deal with frankly, the intensifying pandemic as it spreads across the country into more and more communities. Obviously, we have densely populated urban areas that seem to be feeling getting the front line, the first wave of this, and inevitably everything that we're hearing from public health officials is that it's just a matter of time until it continues to spread and deepen to other communities. And so Dr. Eskew is our first guest in a series of these live streams. We'll have another one next Monday or Tuesday. We're confirming the exact date, probably next Tuesday, and that'll be with the executive director of the DPC Coalition, Jay Keese, who will be providing a federal update. And then we're looking to have a couple other guests on a panel to give a comprehensive rundown of where things stand as of next Tuesday. So just quick intro to Dr. Eskew. He's an AOA board certified physician in both family medicine and correctional medicine. He's an attorney, and he's also the founder of the very popular DPC Frontier website, known for its DPC mapper and a number of other resources. He also serves as the Vice President of Clinical Development and General Counsel for Proactive MD. He's also the General Counsel for the Direct Primary Care Coalition. And most recently, Dr. Eskew, you found yourself fielding and researching a ton of questions from all different people, all different angles about the COVID-19 pandemic. And so thanks for coming on. And I guess we'll just start it off with some questions that I have, and that I think a lot of people have is, one, how seriously should DPC practices in areas that aren't currently feeling the crush? If you're not in Seattle, you're not in San Francisco, you're not in Chicago, you're not in New York, and not in Florida, and some of these other places. If you're in rural South Carolina, how seriously should practices be taking this, and what can they do now to prepare for what's coming?
Well, they need to take it very seriously. I think that was probably an even more important question several days ago, but hopefully everybody's got the gist of it at this point. Lots of people are sick, and we've had a presumptive death in Wyoming already. I mean, it's not been registered. They have to do the autopsy, but I think even in rural areas, people tend to, you've got somebody who's traveling in and out, and the need to do distancing is important no matter where you are. We're all connected these days. So I don't know that everybody needs to hear me preach on that some, but several days ago it was more important, but I think now everybody's closer to getting it. I haven't looked at the news today to see if Miami Beach is still crowded again, but hopefully people will wake up.
Yeah, absolutely. We've heard about the lack of testing availability. We've also heard that that's starting to get better. Chances are that most DPC docs out there don't have access to these tests yet, or good access. Can you talk a little bit about that and what they can do right now to, given the lack of testing, to prepare their patients and communicate with their patients?
So testing is a big deal. At first, before we'll kind of get to this later about some research treatments that are coming up too, but the old academic physician answer used to be, hey, why am I testing something if I can't treat it? And for a while that was kind of true, and now it's, I think, arguably not true, because we do have several treatments that are at least being researched and are worth trying because they're so low risk. assuming you can get them. But testing is important because it guides people's behavior. If you're able to tell people they have the flu versus COVID-19, then they may act differently with one versus the other. So depending on which guideline you're using, a COVID-19 positive, you certainly need to be home until you're at least asymptomatic. The old rules seem to say 14 days. Some of the newer guidance says at least 24 hours without any symptom or without any fever, at least for healthcare workers specifically. So the more people we test, the more we know where it is, the more we can direct resources to the appropriate places. And ideally, I'd like to see more people staying home the way they're supposed to, rather than sort of running around looking for a place to get a test done. The ideas out of Washington, D.C. were to do this in parking lots, which made sense because then you don't have to clean a room over and over. Because when you do a nasal or oropharyngeal swab, you're in a sense creating a problem because you're often going to make the patient sneeze and blast viral particles everywhere. So you're increasing the risk for people taking the swab. I didn't like the new CDC guideline when it came out saying that you didn't need to use an N95. If you didn't have one, you could go ahead and do that with a surgical mask. I think that was folly. And I don't think it fits with some of their other guidance, which talked about 24 hours to clean a given area that you've had a person in if you owned a business. So at any rate, what I hope it'll come to is that there are several companies that are trying to produce home testing kits, and you can just mail those out to anyone and everyone who wants that. I know that the federal government was saying that they wanted to pay for all of these testing kits. Either they were going to pay for it or they were going to have your insurance pay for it. And there was discussion about, having HSAs pay for it with first dollar care for both the visit and the testing kit. I'm not sure where all that is right now, but anyway, there's a big appetite out of Washington to pay for these things and get them out to people. And I would like to see that happen, and I'd like to see it mailed to them. And the mailed kits, the newer ones I've seen, are one of the things they're trying to do is they're hoping to do it with a point of care skin prick testing and have a 15-minute rapid result, which is much, much nicer than swab yourself, mail it back, and wait for several days for a result. So if you combine a mailed kit with a 15-minute response and a DPC physician or some other physician via telemed advising you on the likelihood of that being a true positive or a false positive, true negative, false negative, then you've got a much better situation for everybody.
Yeah, absolutely. I think a lot of physicians out there are handling patient communication in different ways. There hasn't been super clear top-down guidance on exactly what to tell patients proactively. What are you seeing in terms of some of the best practices out there, and in terms of what you're seeing, what you think is the right course of action, and the right way to message, COVID-19, the risk to patients, and what they should be doing?
I tend to say the more information, the better. If people fear what they don't understand, and nobody understands this virus because it's brand new. So all weekend, in fact, pretty much every, last Thursday, Friday, Saturday, even clear into Monday, if I could find a new study, I would try to read it. And I would try to incorporate it into the summary handouts I was making for Proactive MD. And I kind of had, I had my own list there. I found some studies talking about how it could survive in the air for up to 3 hours. So I put that on there and talked about airborne precautions with patients. Everybody's familiar with the hand washing concepts and how long you need to do those things. So we put all those things in there, talked about screening, talked about what 100.4 is considered a fever, ideally to do that with an infrared thermometer if you're an employer, talked about wearing gloves, using diluted bleach, 70% alcohol or more, avoiding groups. And then I put, the other thing that I thought was important to go ahead and put in is, people want to know who's at higher risk. And they always hear about that in terms of age, but they often don't hear about it in terms of specific medications. They might hear about it with chronic conditions, diabetes, hypertension. And there's been a debate back and forth in the literature that I have not seen decided. Maybe somebody else on the call tonight knows the answer to this, but I've seen whether or not lisinopril and other ACE inhibitors may or may not be a problem. There seems to be a debate back and forth. But we know that things like oral corticosteroids suppress your immune system. Biologics like the TNF inhibitors are all problematic. Any kind of chemotherapy, all those patients are higher risk and really should stay secluded. And if you can get vitamin C 500 milligrams 3 times a day, maybe it helps. And then there of course was the study from the French group about the hydroxychloroquine, and then they used that in combination with azithromycin, actually, which seemed to increase the effect of the hydroxychloroquine. So, and there's been lots of other antivirals that are researched too. I didn't put those in there, but I did tell patients, look, a lot of people have this misconception that hydroxychloroquine actually suppresses their immune system, which there's not much evidence that that's true. And so I did put in our handout, if you happen to be taking this medication, stay on it.
Uh-huh. Huh.
So that was in our patient guidance. And then I had a separate packet that was sort of more focused for employers too.
I was talking to Dr. Bliss, Dr. Erica Bliss in Seattle. I mean, again, she's there in the front lines of the hardest hit city in the country. And something that she's doing that I've seen other practices doing, it seems like more and more every minute, are closing to in-person visits and encouraging, basically requiring all patients, unless there's, unless basically approved by the doctor, all patients would come through virtual care for the time being. And that's to protect both the doctor and the care team, but also the patients, right? The quote unquote healthy patients.
Right.
So I was thinking about this. We got a question from Rachel Huerta on the line, and she says, thoughts about practices staying open to see healthy patients. And before you answer that, I just want to let everybody know, a little housekeeping. On your screen, you should see a Q&A button there, I believe at the bottom or on the side. So you can tap that and then write your questions in there, and we'll do our very best to get to all the questions.
I think the answer is, should you stay literally open? I would say yes. And I guess the better question is, how do you do that in a way that makes sense to you? If you were used to being in urgent care on the side and you had a high volume and you've got enough sort of one room after another where you can actually isolate people who may come in with symptoms and quickly move to a certain area, and I suppose you could do that. If you're a very small operation and you've got one or two rooms in your entire facility, then you may want to debate whether or not you need to be open but have the door kind of locked and open it for people based on scheduling, because you may have a patient who's overly anxious who shows up and comes in coughing and sort of shuts down your operation for a while and exposes your staff, and now you all have to isolate even more than you were. So you can stay open, and if you're careful in how you triage and how you decide to see people in person, I think that may be the best step if you think you can manage it and if you trust your patients and that kind of thing. But the minute you slip up, the minute you expose yourself or your staff or have to close the place, then you're back to 100% telemedicine. So you have to do it very carefully. If you don't go 100% telemedicine right off the bat, there's a chance you have an exposure that requires you to do that anyway.
Good advice. Yeah, actually, we've got a follow-up question here from Maribel. Pardon me on names. I'll do my best. Maribel Aviles. She's asking, can you comment on the new telemedicine law and DPC non-hybrid practices? Okay.
So as far as the telemedicine piece goes, they've made a couple modifications. So one, they changed the HIPAA rules a bit. They gave a waiver for it. So, you can use Spruce or you can use Hint or a variety of other resources that make it free for you to have a face-to-face visit, kind of like what we're doing now. But the government went so far as to say, we just want you helping people. And even if you're doing this with something that's traditionally not so secure like Skype or even FaceTime, please just see your patients and do what you can for this crisis. So with that kind of order out there, I guess I would say that almost everybody should be able to find some vehicle where they can meet their patients where they are. As you might imagine, especially some of the more elderly patients, they might not be all too attuned to downloading a new app, but they might know how to use FaceTime because they were already using that for their grandkids or some other popular format. So I believe that's why they put that in there. As far as hybrid or non-hybrid, if you're DPC, of course, that I guess if you're only DPC, that question doesn't matter to you too much because this is just worked into the monthly fee. If you had a hybrid practice or a traditional practice, or if you want to moonlight on the side, weirdly enough, with patients that you don't have an established relationship yet, Medicare is saying that they're going to pay for those visits on a fee-for-service basis, even if they're at home, which traditionally they wouldn't have done. Traditionally, in order for Medicare to pay for a telemed visit, you had to go through a lot of hurdles. The patient had to be in kind of a rural area. they couldn't be at their house. They had to go to somebody else's office, and then you had to see them at that office. So all those hurdles were promptly removed, and they tried to make it as easy as possible to do telemed from home. States already had freedom to do that within their Medicaid programs, and how quick they act might vary from one to the other.
Great. A question, one thing I've seen is, Medicare waivers and regarding Medicare. And so we had a question from Cynthia Velasquez asking, what about treating Medicare patients if you are not opted out? Any changes there?
So if you're not opted out and you want to take advantage of this telemedicine piece, then you can, they basically changed the billing laws, and I don't have the codes in front of me because I hate learning codes generally, but there is a set of codes that you can use for telemed visits and get paid for that. And you're even allowed, if you want to, which is normally this would be a civil monetary penalties violation, but you're allowed to waive the copay if you just want to take payment from Medicare for those calls. And depending on what platform you're using, there's lots of different telemed platforms. And depending on what that corresponding state has done, you might find that you're suddenly able to practice in a lot of states, even though you only had one license. So I know off the top of my head, for example, that South Carolina has said, we don't care what state you're originally licensed to practice in. If you have a good license and good standing there and you want to do telemed with our patients, go for it. Colorado said that, and then they went a step further and they said, okay, not only does that apply to our patients generally, it applies to our Medicaid patients. And we don't even care if you retired 10 years ago. If you want to come back and practice, we will be happy to have you in whatever format you choose. And one other thing I might, if I could go ahead with it,
Sure.
So the waivers that were mentioned a lot were Section 1135 of the Social Security Act. And if everybody will humor me, I got a little bit of a passage that I wanted to read to you. They said, pursuant to 1135, they hereby waive or modify the following requirements, and then they listed several titles. And then they said, insofar as they relate to several more titles, in each case, only to the extent necessary as determined by CMS to ensure sufficient healthcare items and services are available to meet the needs of patients enrolled in Medicare, and then they go on. And then they say, you may be reimbursed for items and services exempted from sanctions for such noncompliance, absent any determination of fraud or abuse. Certain conditions of participation, certification requirements, program participation, or similar requirements will be waived. So basically, they've given discretion, in my opinion, in my reading of this, to CMS to say, we don't care what, if they want to. And I've asked them via email, but I haven't received a reply yet. Theoretically, they could use this and say, we don't care what your status is. You can see Medicare patients in this setting and I guess be reimbursed by the government regardless. So you could be participating, non-participating, opted out, or totally unknown to them. And theoretically, they would waive it during this emergency time period. And this was enacted on the 15th of March and was set to be in place for 60 days with discretion to the Secretary of HHS to extend that on a rolling 60-day basis over time if they want to.
Gotcha. I wonder what the over-under is on that getting extended past the first 60 days.
I don't know.
So a follow-up question there. Should there be, are there any other legal documents outside of HIPAA that doctors should be collecting? They usually just have patients sign the HIPAA and member contract. And that's a follow-up question from Rachel.
So HIPAA does have a 72-hour waiver where you don't have to do a notice of privacy practices, at least immediately, in a triage system if it's in a hospital environment. If you're having a new patient sign up for an urgent care visit over a telemed platform, I suppose I would still try to recommend that you had some sort of agreement in place. I think those kinds of things are often going to be overlooked right now, quite frankly. There's obvious appetite to do as quick a triage as possible everywhere. Ideally, the platform you're using would have some kind of agreement that you could populate yourself as like a click-through agreement that sort of briefly described what you were doing and how you were still trying to take efforts to be secure, just like you would always do in your HIPAA documentation. The other thing I'll mention, in case anybody's looking at doing hospital work, so EMTALA, the Emergency Medical Treatment and Active Labor Act, typically requires ERs to medically screen all patients that show up at their doors. There's a waiver right now where they actually don't have to do that. And there are lots of hospitals that are locking all the side doors. so that there's only one entrance, and then outside of that entrance, there's a tent where they're trying to do outside testing and triage people outside. So that's something to know, and it's important if you're trying to do any ER work, make sure you have enough PPE, and hopefully they're taking those steps to limit the risk to their staff.
Great. We've got questions are starting to roll in now. That's good.
One more thing.
Okay,
Sorry, if I could, Nick. So I don't forget to say it. It's probably one of the questions, but one of the things that I think was in Trump's announcement was on waiving of state licensure requirements, sort of at the federal level. When I first saw that, I thought, oh, that's a nice idea, but you really, in my opinion, and I think this has been confirmed by others, you really don't have the authority to do that at the federal level. So you got to rely on each state to do kind of what South Carolina and Colorado have done and open their arms to people from other states if they want to do telemed that way. I don't think that the interstate licensure compact gets you much further along than you would get from a regular license at the moment.
Just wanted to move on to one more question. What about Puerto Rico? This is from Maribel Avalos again. Puerto Rico and MCRE waivers. Do you have any knowledge about that?
I don't have a comment on that one. I'm not sure.
Okay. We're, we can't bet 1,000 on this thing. It's unrealistic expectation. But we will, we'll look for that answer and see if we can get back to you, Maribel. Let's see, from Robert Nieto. As far as doing telemedicine in other states that you do not have a license, what about our own medical malpractice carrier having issues with that?
Well, your medical malpractice carrier would have an issue with you practicing medicine where you're not allowed to do so. And my argument to the carrier, if they tried to give you any grief about this, which would be terrible PR for them, would be that you do have a license to do so because the state decided that you did. So practicing there during this crisis still falls within what you're allowed to do legally. So I don't see where that would create a malpractice problem.
Yeah, and a little bit of voiceover there too. And I want to be careful about how I talk about this, but what we're hearing, Phil, I think what you and I both heard from Jay Keese, who's our guy on the Hill in Washington, who's working behind the scenes on a lot of this legislation that's coming out, is that those requirements, there's some talk about those being relaxed or eased, and I think maybe FEMA will step in and do that. But I was talking to Erica Bliss yesterday, and she said, the last thing the government's going to do is prosecute anybody for that right now. Right. And that is my non-legal, non-medical opinion, but just what I've been hearing, speaking to people behind the scenes. Mm-hmm. Is that generally what you've been hearing too?
Yeah, I think that's an accurate characterization of it.
Yeah. So, desperate times call for desperate measures. Broad question here, very important one though, from JDC. What legal pitfalls would you advise us to be wary of in the midst of this crisis? What do you think are some of the biggest legal sort of gotchas or landmines that are out there for practices right now that maybe will not be forgiven?
Well, the biggest one is really a medical one, in that you would miss a case of COVID, tell somebody they were cleared, and then come back at you for that. I think a lot of them come up in the employer side. So I know a lot of DPC physicians out there serve employers, and you are employers on your own, and you have to decide, you have to make judgment calls about where people, if somebody can work from home, they really need to be working from home. If they could have worked from home and it would have been pretty easy, and you said, no, we need you here because everybody else is here and you're not more important, your safety isn't more important than anybody else's safety. That kind of attitude is a wrong attitude. And now if it gets passed around the office for whatever reason, and they could have been home and not exposed, then it makes you potentially liable there. A lot of this hasn't hit family medicine as much, but a lot of the surgical societies are making it really difficult on some of their own surgeons who may have had their own outpatient surgical center, and maybe they were trying to screen people and continue to do procedures, because if you delay everybody's procedure for 8 weeks, it might not be too big a deal, but this may get extended to 16 or 20, and then those things that weren't emergencies are. So if you're trying to find ways to keep things like that open, it gets really dicey from an employer standpoint. So you have to have as best a screening process as you can, which unfortunately right now is limited to symptoms and checking somebody's temperature. If we had a lot of dirt cheap rapid fire 15-minute tests available, then our ability to do that and continue to function even as some people have this goes way up. So I would love to see lots of home testing kits widely used in that manner so that people can still feel like they're functional and minimize risks appropriately and keep the flow of essential goods going to grocery stores and that kind of thing with minimal disruption.
Absolutely. Question from Dr. Gold, Jeffrey Gold, our friend up in the Northeast. What do you think the likelihood will be? So a little bit of a hypothetical question here, but maybe not. What do you think the likelihood will be that if doctors in ERs and hospitals get sick and can't work, that we will be recruited in, so that primary care physicians will be recruited in?
That's a hard question. I don't know. I think that may happen in certain areas that already seem to be hit the hardest. It depends how quickly. It depends if if the early studies are good on the Black Widow and how fast they can mass manufacture that and how seriously everybody takes this. There are just so many variables there. But I do think that's part of the reason I tried to pose those questions to various Medicare and Medicaid authorities at the state levels to say, look, the guidance I've read says you're trying to swing those doors open to have all kinds of backup troops, which for a lot of cases would be DPC physicians that have had to be outside the system for various reasons. And so we could do those things. And if you feel comfortable doing that, if you trust the hospital and you want to do that, I think you will find yourself with an open invitation, ideally pretty quickly within the next week or two. And I don't think you'd need to wait for 4 or 8 weeks, but of course, it would make sense to sort of expect a rolling timeline of diagnoses here, right? Because you have this first wave of patients that show up, and then depending on how good the PPE was in place, you're going to knock all the providers at the same time. So,
right, yeah, I mean, everything that that I'm hearing, and that I'm sure everyone's hearing from, again, credible news sources and the public health officials, is that the lack of testing is sort of where the tsunami is going to come get us. It's not, and I think the curve that we've been seeing is we're just on the upper inflection of some kind of curve, and time's going to tell what that curve looks like. And
the biggest challenge for hospitals and even for us at a smaller level is if you have this many people that are asymptomatic spreaders, then you and maybe totally afebrile too, you got to find a way to do a rapid test, and it might mean, it might really knock out your workforce, because you might have had a lot of people that said, I'm working, I feel fine, I'm good to go, nobody else can manage these events, I'm already working 24 hours here, and then you get a positive. What do you tell those people? So you're gonna be trying to gather any physician you can in the community to help out.
Yeah, well, and I think all of this underscores, and even just the nature of the question, right? It underscores the importance of one, taking this thing seriously, not waiting to react to a worse situation, but thinking proactively and doing our best to get ahead of it locally where we can to prevent that from happening. And that's why I think strategies like Dr. Bliss's of really instituting mandatory virtual care only,
Right.
with exceptions, is the better safe than sorry approach for sure.
Yeah, I would agree with that.
And that could be one of the single best things that practices can do to protect their own workforces, their own teams right now in areas that aren't apparently, don't have any apparent COVID-19 cases yet. Question from Marguerite Duane. Would it be possible for a person with probable COVID-19 patients to obtain their own test sample, or to have a family member or close contact obtain the sample? She's saying this would significantly reduce the need for PPE. As a house calls only DPC doc, I could do a telemedicine call from outside their home, provide a test kit for them to perform the test themselves, and then deliver the sample to the lab. So in terms of workflow and how that all works, thoughts?
I think that's a good idea. Right now, I think it gets a whole lot easier, like we talked about earlier, if you get some a finger stick version. Right now, it might be a little bit hard to trust somebody to get an accurate um, nasopharyngeal sample when if they don't have any medical background. Even though the family members are probably willing to do that, even if they don't have a mask, because presumably they've already been exposed to each other and kind of around each other for a while. What I it's better than nothing, I suppose. And so that's what I would say, is that it's okay. I suppose it's okay to do. Everybody sort of understands the risks with that, and you want to disclose that to the family member who is getting it. I suppose I would tell them the same thing that I would tell our staff, or anybody else who's in a situation where you're trying to get a sample with either insufficient or PPE that you're worried about in some way. So do it outside, do it in an open air setting, and stand back and get away from the sneezing and that kind of thing. When the patient, if you are taking care of somebody in your household who is ill, try to keep them in one room. And if the air is warm enough that you can open the windows. The better ventilated it is, the less likely it is to spread to everybody else.
Absolutely. Got a question here from Hannah Shelton. So Hannah asks, what's your opinion about nurse practitioners self-testing? Do you think patients will be able to do a proper, oh, sorry, not nurse practitioners. See, this is where my my lack of medical, I think this is the nasal pharyngeal, the NP test, self-testing.
Okay.
Do you think patients will be able to do a proper NP swab and not just get false negative results?
I think there's a high chance they mess it up. I think it's easy to mess up even if you're trained in it. I mean, it doesn't feel good. You got to go way back there. And I've seen in some of the studies I read, the sensitivity and specificity vary quite a bit. And I think it's partly because it's hard to do it the right way.
Yeah. So they could get I think her concern there, she mentions, is, they would get sort of a false sense of security or reassurance if they.
Absolutely. I mean, even if you look at the newer study out of Italy that I liked, they followed these viral loads down over time as they dosed patients with Plaquenil and azithromycin, and there were a few in there that went positive, negative, positive, and they kind of alternated. So, as careful as everybody's being, they can still kind of flip on you like that, and it's very frustrating.
Yeah, that's great. Good question and a good thought there, Hannah. Thank you. Follow-up question from Dr. Gold, or another question. He says, how can small independents like us even get PPE and testing? He says, we can't get Jack up here.
Well, I mean, we were looking for masks at hardware stores because those were the groups that still had them. You couldn't get it from McKesson or from any of the usual suppliers, and supposedly all that's changing. And you see the news stories about China finally having some extra masks that they're mailing to the United States. And if you don't have PPE, then all the more reason to do 100% telemed, like Dr. Bliss was saying, to the extent you can. These tests should be easier and easier and easier to get. And right now it's everybody's frustration, and I don't have an answer for that. I don't recommend exposing your staff to it without PPE. Maybe if you're real bold and you have lupus and you're already taking Plaquenil, maybe you feel lucky and you want to do it. But I don't recommend taking that risk, because if you knock yourself out, that's one less troop in the army to battle this, quite frankly.
Right. Have you, do you have any knowledge with some of the kind of, frankly, the kind of the wartime hacks that care teams around, in certain hotspots are having to do? I've got a contact at UCSF who's said they're already looking at, they're just using surgical masks once they run out of the N95s. And I know that's happening up in Seattle as well.
Right. And I think the CDC made that guideline kind of, as a calculated sort of judgment overall, which might make sense for population health, but sometimes it doesn't always seem to make sense at the individual level, where they thought we need to get all these tests done, and we don't need the lack of N95s to be a barrier to getting these tests done and getting people potentially treated with some of these pilot medications, or trial medications, I should say. And yeah, I don't know. I guess that's all the more reason for people to ask those questions about self-testing and other options, but it's everybody's own judgment call. That's not, I don't know that I have a legal answer for that kind of thing or even a medical one.
Sure. As far as testing, this is from Roberta Nieto. Do you think that a negative COVID-19 test is false reassurance in the sense that if they're negative once, that they, they could still become positive later? And just how to manage that with patients?
You have to, so everybody needs to pretend that they're COVID positive, regardless of whether or not they have have had any formal testing. Because you just need to assume you're an asymptomatic carrier. So
and assume that other
goes,
people are asymptomatic carriers.
Right. So that goes back to the stop shaking hands, stop hugging. If you're going to sneeze, put it in your shoulder. And you have to routinely, be mindful of this. If you start to have a fever, don't blow it off. Actually check it, and even if it's if you feel it, if you know that that's happening, isolate yourself and check it again. If you checked it 2 days ago, well, maybe you were negative 2 days ago. Maybe you got exposed since then, because a large chunk of people walking around you have this. So you can't rely on this is not a Hep C test, and you can say, well, I didn't inject any drugs, so I'm not going to get Hep C in the next 2 weeks. This is very, very different. So one negative is brief reassurance for a brief time period. And ideally, we'd have millions of these tests all over the place, and they'd be $1 a piece. And you could, do a finger stick each morning as you're going off to work. But we're not there. And until we are there, you have to be very, very vigilant about all of your symptoms and be extra careful.
Good advice. Cynthia Vlasis is asking, what do you think the liability is for using, or is there any liability issues for practices using N95 masks they've purchased from Lowe's or some other home improvement store that haven't been fit tested with their teams?
I think that's better than any alternative. So I think that's wise. I think you just it's like anything else. You disclose the risk. If you're given, just think back to if you're giving a patient a medication that may cause some side effects, you disclose that up front, and you disclose that to your staff. Look, we don't have fitted masks. We're not going to get them anytime soon. We put an order in. We're trying to get you fitted, and this is what we have right now. And if you can be home, stay home. If you can't, you can. If your job is essential that you be here, then you come in, and we are limiting your risk as much as possible. So if staff is comfortable with that, then they can stay and work. If they're not, then you have to address that, and it could be challenging. Some other kind of things that I'd highlighted that I want to get in so we don't miss them.
Sure.
Kind of along the employer kind of risk setting. If you have staff that are looking to take time off for this, any kind of PTO or collective bargaining agreement, then if that's in place, then you pretty well have to give it to them. There's supposed to be a stimulus package that's going to address some of this stuff. FMLA still applies. They can get 12 weeks of unpaid time off. If the patient, if your staff member becomes a patient, if they're positive or they're suspected positive, then there's an argument that they now have a temporary disability under the ADA as well. So you got to remember that ADA rules would apply. I think that was the big stuff that I wanted to make sure I didn't miss that was on part of my employer handout.
That's great. Very important information there. We've got a couple more questions here. And we still have some time. So if you've got questions, now's the time to get them in, and we'll see if we can burn through these in the lightning round. So Maribel's asking again, can you review sanitation details for testing that's performed in a small practice? Do you have any references or?
Well, I've got a handout that I put together for Proactive MD that I should be able to find a link to. I think it's online afterwards that I used, but I just went through and kind of made my own based on stuff that I saw from the CDC that made sense to me, and some things that didn't make sense based on some of the studies that I read. And if you put some things together, if for example, that the virus lives in the air for 3 hours, that it can live on top of plastic or stainless steel for 72 hours, that it can survive on cardboard for 24 hours, that it can certainly be passed from within 6 feet and maybe more, depending on the airflow theoretically, then you would know that you need to take certain precautions based on that information. If you're going to clean a room, you need to do it with something that's at least 70% alcohol or with diluted bleach. And so if somebody comes in my front door and I have a small clinic and they're coughing and they say, I think I've got COVID, and I agree, and maybe they get, we have a high suspicion, we send them out for testing or we do the testing or what have you. They've already coughed in the lobby. They've already coughed on some of us. So number one, we've got a high suspicion and we need to find a way to be extra vigilant about ourselves. Probably already go ahead and isolate ourselves if we've been exposed that way, anybody who is exposed. You would leave the room, you would leave the area and wait. I would probably wait for 3 hours or more because I'm going to wait on it to get out of the air. I'm going to let it sort of precipitate down, hopefully on the countertops or whatever else. And then you're going to go in and clean all that off, ideally with your N95 and other protective equipment on. That's the procedure that I would try to follow.
Great. Yeah, I mean, I think it's everyone's doing the best with the materials and the procedures that they have at hand. Good advice, and really important to remember. It's good that those studies have already come out in terms of how long the virus lives on different surfaces.
Yeah, I'll tell you what was really disappointing to me is that it can still live for 4 hours on copper, and copper kills almost everything. As far as the other question that I've gotten a lot is, we've only got 1 or 2 masks. Can we reuse these masks? And I would say a reused mask is better than no mask, especially, if you get something soiled on it, obviously you probably got to ditch it. But if there's nothing visibly on the mask and you think that there are just viral particles that have gotten on the outside of the mask, what can you do about that? Supposedly UVA light is toxic to the virus, so you might leave it out in the sunshine, old-fashioned sunshine. And most of those surfaces that they tested, it was dead eventually after 3 days. So if you maybe had several masks, you could rotate them. You would use one on Monday, leave it out in the sun, wait 3 days, and then maybe come back to it on Thursday if you're sort of rotating through. You could try something like that as a sort of self-triage with limited equipment.
Question about any preliminary data about what's going to happen in prisons. Are they prepared to properly quarantine?
That's a very difficult subject. If you look at what happened overseas, I think Iran, they released like 40,000 inmates because they were at too high risk and they weren't able to effectively quarantine. And that is the proper word. And there's a difference between social distancing and between quarantine.
Right.
And there was a really good, I can't remember if it was Wall Street Journal or another article that sort of showed those differences in graphic form. And quarantine is what we kind of did with China, right? With the banning of all flights from China, we sort of delayed things getting over here, but because we hadn't had meaningful social distancing, once it was here, it still spread like wildfire. And that's the problem that you can have in a jail or prison setting, is that you can only separate people so much. At least in the United States, pretty much everybody has a roommate. They're all going to the same place to eat. And they're getting lumped in various areas at various times. So you can lock the facility down. You can limit visitations and have more phone calls or more Skype calls available to inmates that are there in lieu of those visitations. And you can try to cohort vulnerable patients in an area that's maybe better ventilated or more secluded in some ways. But you always have these sort of bundles of people here and bundles of people here, where something that is airborne, it's really hard to separate them.
Yeah, I just want to get to one or two more questions here in the last minute or so, if you've got another couple minutes to hang around. So Dan Schaefer asks, this is a long one, so I'm going to see in here. So it sounds like Dan's been doing they've done 4 COVID-19 tests this week after conducting negative rapid flu tests on their patients.
Uh-huh.
And they've done this in it sounds like a drive-through setting with patients in their vehicle on public street outside of Dan's office. So they've done it outside the office on the street. They're informed yesterday by the building owner that a neighbor who lives next door to the office said they videotaped somebody in a hazmat suit out on the sidewalk, and the neighbor wasn't comfortable with that, or the building might not be comfortable with that. Should they be concerned here in terms of legal ramifications? Do you see any sort of potential legal exposure to the practice for what's going on the sidewalk to address, what's really a national public health emergency?
No, I don't see any legal liability there. They can get over it.
Tell them to chill.
That's what I have to say about that. That's why you stay home. That's what I
Yeah.
would say to that person. If you don't like what's going on the street, stay off the street. Because right now that's the best place to test by far. They're doing it exactly the way they're supposed to. The CDC will back them up on that. Yeah, there's no legal liability that I can see right there.
Dan, you're the salt of the earth. Don't let anybody else tell you otherwise. Keep doing what you're doing. And then Cynthia has one more question. With the mask shortages, the PPE shortages, we're seeing all kinds of things pop up online. What about these, people are seeing masks on Amazon. The price is a different question. That maybe, masks from, it doesn't really matter where they're from. I'm assuming actually most masks are probably made overseas anyway. But have you heard any danger or any concerns with getting masks online through sort of regular consumer channels versus through the healthcare supply chain?
Well, sure. Yeah, there's all kinds of fraudulent masks out there. I don't have a way to tell you whether or not it's an accurate mask or not. You probably need your own testing facility of some kind to know that. So I guess buyer beware is what I would say. Groups like Amazon are trying to police that. I think eBay's probably trying to police that too. At least the people who are trying to sell them for way too much money, they're policing that part. But can they prove quality from one person to the next? No. I mean, they can't. The ones that I've seen at our office, I mean, they come in packs of 10 or so, and they've got a little tie at one end, but they're not each packaged on their own. So you don't, if you buy those online, you don't know that I didn't already use them and put them back in there. So I don't have a way to sort of certify that or comfort you in any way there. You have to make sure you trust who you're purchasing that from.
Yeah, absolutely. So we're out of time here. I wanted to mention a couple things to everybody on the call in terms of kind of what's happening next. So first of all, this session, this live stream with Dr. Eskew will be posted on hint.com/COVID-19. So we've set up a COVID-19 war room on our website, and we'll be posting Phil's live stream plus future live streams on about the COVID-19 pandemic and what the DPC community can be doing both to prepare and to respond and really to join the effort to fight this thing across the country. We're spinning up. We're not quite ready to announce this yet, but we are spinning up an initiative to mobilize the entire DPC community, whether practices are seeing in their communities or not, but using virtual care as a way to basically to help out in areas, hotspots that are seeing and will be seeing increasingly a severe lack of access to primary care as more doctors just get pulled into the local fight there. So look for that. That site is up now. So if you offer virtual care or you're interested in offering virtual care as a way to pitch in, you can go to hint.com/virtual care, and there's a little link there to sign up and join the effort there. And what we're going to do is we're listing those all those practices right now, and we'll be working with. I anticipate we'll be working not just with the DPC Coalition and the DPC Alliance, but also with federal and state authorities to circulate that list and again match DPC capacity with needs, with surge capacity needs in other areas of the country. So hang in there, everybody. Thanks for joining, and we will be back next week. You can also sign up, by the way, for updates and email alerts about future live streams on this topic at hint.com/COVID-19. So check that out. And thanks for joining, Dr. Eskew. Thanks so much for your time. Listen to you talk for hours. I'm sure everybody's. All right.
No, it's not that good. All right.